So let me start introducing myself. I have this very long Turkish name, so most of my patients call me Dr. I, and I do see a few familiar faces. Thank you for having me, Dr. Jen, and thank you for coming here this afternoon. I know you could have done other things, even though it's a little gloomy out there. This is a fun conference, and I am myself still learning a lot from Dr. Jen, so thank you again. So Dr. Jen did a wonderful introduction. I'm not going to repeat all the good stuff she told you. I just wanted to emphasize a few things. When I see my patients, when I talk to my families, as providers, we sometimes use this medical terminology, and sometimes it's hard to step back and imagine yourself in their shoes. Most of the time, what I emphasize as a provider is when we're talking about CP, we're talking about a chronic lifelong condition. And yes, we know it's a neurological condition, but we also know it's a dynamic process. So with your child growing and the brain of the child changing and maturing, there's a lot of changes that happen over the years. And we need to always kind of emphasize that and base our treatment modalities on that. It's a movement disorder, and Dr. Jen did all the, gave all the information on that. It's a multi-system involvement, so again, it's head to toe. There are many different organs, many different functions involved here. So when I'm talking about a treatment recommendation, I need to make sure I'm addressing all these with the families. And yes, there is the hypertonicity or muscle overactivity or spasticity or dystonia, whatever you want to call it, whatever we diagnose you with, there's always that muscle tone that we're dealing with, and what I'm talking about today is tailored towards that. And then, of course, every kid is different, every family is different, and every goal is different. So whatever I choose as a treatment that I make a recommendation on, I need to make sure it's meaningful to the families and meaningful to that particular child. And of course, always remember, I'm a part of a big team, and I'm a big believer in a teamwork. With CP, we all know it takes a whole village to manage kids and their problems. So starting with that, again, I'm not going to repeat any of this, but with CP, we get different manifestations, different presentations, whether it's one side of the body, it's one limb or both, or lowers or uppers. There are different treatment modalities for all these. On the movement disorders, depending on what type of movement disorder we diagnose you with or we think the kid has, we are going to base our treatment modality on that. That will be our starting point. As a physical medicine and rehab doctor, again, I'm not a neurologist. I'm a physical medicine or pediatric rehab specialist. And to me, when I step back and look at the kid or the family, I'm trying to look at the big picture, and I'm going to always focus on function, what we can do for our families, for our kids to make them more functional. And when I say function, quality of life is in there, and also standing in a standing frame is a functional goal for me. So it's not only about walking. Spasticity or muscle tone is very complicated. This is just one slide that I wanted to share, kind of to show you how complex it is and how much work it takes from the spinal tracts and the control from the brain cortex that plays into this muscle tone. When we're talking about different treatments for spasticity or muscle hypertonicity or dystonia, again, we need to always approach it in a very unique way. And we need to keep in mind, whatever treatment we offer, it will have to be a part of this integrated treatment plan. So it will be multimodality. When we're talking about muscle tone, you can't be only prescribing one medication and forget about everything else. You will still worry about your therapies. You will still hopefully come up with the right splint. You will still talk about different equipment-assisted devices. You'll talk about different therapy modalities, bringing it all together. And even though the treatment plan needs to be individualized to that particular kid, and it has to be a family-centered model so that our families, again, our treatment recommendations make sense to the families, and that makes their life easier, and that means, certain goals are being met for that particular family. Some of those goals need to be realistic and need to be discussed, and some of those goals for me are symptom-based. I'm trying to maybe target pain, maybe a contracture prevention, but also they need to, again, be meaningful for the family, but also supportive for our kids and families. Now, when we talk about the medical treatments, we always like to classify it, whether it's focal or general, sometimes regional, depending on the involvement of the kid. Are we talking about muscle tone in all four extremities? Are we talking about just one limb? Are we talking about one particular muscle group? So that kind of helps us decide on what we're going to choose in terms of medication or treatment modality. Going back to the neurotoxins or botulinum toxin, we need to emphasize this to our families. It's a very reversible modality. We're talking about a temporary or a short-lived kind of modality here. It's not going to cause any permanent changes. This is not a surgical modality. This doesn't have any permanent long-term effects based on the 30-year experience we have on these toxins. And again, going back to the general treatment, sometimes we use medications, sometimes not. Most of the time we combine both pharmacological and non-pharmacological treatments. Even if we combine the medications, still, we need to keep in mind, when we're doing that, we need to have a good reason justification for our kids. Because every medication has a different mechanism, and when we're combining them, they really need to make sense. And usually we try to shy away from multi-pharmacy, and Dr. Jen is big fan of minimizing medications because of the cognitive effects she mentioned. And that's very true. We see that over the years, the more anticholinergics we use, the more muscle relaxing medications we use, we're not really sure how we're impacting their long-term neuro recovery. And of course, there's always surgery as an option for our muscle tone. So, going back to the goals are always multiple. So doing one modality, doing one injection for a particular patient, to me there's not only one goal involved with that. It has to be multiple goals. They have to make sense to the family, and I need to be able to justify that in my mind as a provider, so that I know I'm doing some good and I'm not causing any harm. The idea with the neurotoxin is, again, we're dealing with dynamic misalignments, meaning we're talking about a muscle tone, like spasticity, that doesn't cause any permanent deformity in the joints. Otherwise, the neurotoxin is not going to do any good. And of course, the goal is reducing the tone, managing the tone as much as we can, and by doing that, preventing imbalance between flexor and extensor groups. So if we're talking about the upper extremity, if it is the flexor group or the extensor group, having tone and different weaknesses or muscle strength issues across the limb or across the joints, we need to be able to balance it out. And the dosing of the neurotoxin, the targeting of the muscles, we have to keep this in mind when we're coming up with that final plan. Big goal is pain. Most of our kids with their spasticity and spasticity leading to some musculoskeletal secondary deformities have pain, and neurotoxins may help it partially or sometimes more than what we believe they could. They really help control this pain. And by doing that, they also increase the tolerance to the splints, the AFOs, SMOs, whatever else we're giving them. They're able to do more in therapy, and they're able to use their assistive devices and do more with their standing frames, gait trainers, or walkers, or whatever else. For the family, again, what we do with our treatments, including the neurotoxin, we are trying to simplify life for them. We're trying to make it easier for the families to take care of our kids. Neurotoxins are also used for glands, for drooling, for salivation. In my experience, it's 50-50. I do get some good results with the reduction of the amount of secretions, and then I have patients that we've tried it over the years, and it's like it's not doing much good. But it's a modality, and we do use it, we do offer it. At the end of the day, if there's any function that the family is worried about, or if it is their goal to make their function better, that's what we're trying to establish with our neurotoxins. Remember, it's just one modality, one part of the picture, but ultimately, if it is going to make our kids sit up taller, if it is going to make them tolerate the standing frame and be upright for extended periods during the day, or if it is going to make them walk better, we're all for it. And function, quality of life, to me they go hand in hand. Sometimes we can make really big progress in function, sometimes not. But then quality of life is huge, and if we can help improve the quality of life, That's a very good goal for us. And at the end of the day, yes, we know our kids are growing, and as they grow, they may have more musculoskeletal problems, and they may end up needing surgeries. But if you are doing the modality, the neurotoxin, yes, we're trying to reduce the pain so they can tolerate their surgery better, but we're also trying to maximize the outcome from the surgery, hoping we're helping the team, including the surgeon, to do their job and get better results out of that. And of course, there's always the hip joint we worry about with lower extremities and spasticity. We're hoping we can prevent or slow the progression of that hip dislocation, hip displacement, by managing the tone better with neurotoxins. So talking about the toxins in particular, well, it's a toxin that's produced by the bacteria Clostridium botulinum. The clinical syndrome can result from actually this bacteria contaminating certain food items, or it can be an infected wound you can get it from. There are different serotypes isolated, A to G. They all have different potencies. The effects are reversible, and this is very important for me to emphasize. Whatever I do with the neurotoxin, it is reversible. It's not going to be permanent. There are patients I wish it would be permanent, but it's not. And then there are patients I feel like, oh, okay, maybe we should have done a different dosing. It's good to have this on my side because this helps me to fine-tune and come up with the exact dosing. Sometimes it takes a few injections to figure that out. And the muscles will function again upon clearance of the toxin from the affected neuronal cells. And it's a very local application. The good thing is being local, and the way we do it, we're hoping it's not going to spread to other parts of the body because we're choosing that particular muscle to put the medicine in. We are targeting that muscle for a particular reason, and we don't want this toxin spreading anywhere else and causing problems. So yes, theoretically it can diffuse, but we're hoping it's going to be a very slow process. It's not going to be fast spreading out too. So basically what the toxin does is, and I'll show some diagrams shortly, it does block the release of acetylcholine, which is the neurotransmitter that acts between the nerve ending and the muscle. It's temporary reversible, it's titratable, so I can definitely titrate the dose based on the effects and the response and the duration. It's very focal, it's an intramuscular injection, so I'm injecting it into the muscle. We combine it with other modalities, always. There's always some other modality we're going to use. Again, in spasticity, in hypertonicity, dealing with muscles, you can't rely on one medication to do the job. It just has to be part of that whole treatment plan. Resistance is rarely seen due to antibody formation, and again, the effects are dose dependent. So dosing is very important. Different types of toxins and target sites. Again, looking at the dates, look at this. The first time a German physician came up with this toxin, like 1800s. And then it took us like a good 120 years for us to use it in the humans. So 1980, I think, is the first time it was used in humans for strabismus, the eye muscle. And then 1989, it was approved by FDA for that use. Keep in mind, with all the different serotypes, different types, they're all different. The way they work differs a little, and their potencies are different. And I can't emphasize this enough. There's no converting one toxin, neurotoxin, to the other. The dosing, the units, the potency, the preparation, they're all different. So it has to be done by somebody who's experienced in this, and it's not always that simple to convert the dose. Now the structure of the toxin, again, it's an inactive form. It gets cleaved or it splits into some products and becomes active. There's a light chain, there's a heavy chain. Not that you need to remember any of this, but okay, you can do this. Okay, here we go. So this is a good summary of what happens in a normal tissue. This is the nerve ending. So this side is the nerve fiber, and this side down here is the muscle. So there's this area between the two, nerve and muscle. This area is called the synaptic cleft, where some of the neurotransmitters, the acetylcholine, gets released into and makes it across to the muscle and starts the contraction. So this is the place where Botox is going to be coming into picture and blocking it. Another diagram just showing the same thing. Nerve fibers with all the branches, the sprouting. At the very end, we have the little bags or vesicles full of neurotransmitters called acetylcholine. This is the junction, the cleft, the area between the nerve and the muscle tissue. The part of the muscle that I'm targeting in my injections is called the end plate region. This is where actually where we put the Botox in, and we're hoping the Botox will make it across to the nerve cell very easily and quickly. And then this is where the toxin comes into place. It gets into the nerve cell and blocks the fusion. So again, vesicle, cleft, muscle. And now let me see if I have the next one that shows the actual toxin with the heavy chain, light chain, the whole structure there. And this is with the permission of Allergan again on a botulinum toxin or the good old Botox. The Botox comes and attaches itself to the bag of neurotransmitters, and the way it breaks the proteins, the neurotransmitter storage is in here and it's staying in here. It's not going to be released because of this altered protein structure due to the Botox toxin. It's a complex process. Now, there are different generic names, there are different products for neurotoxins or botulinum toxin, and I wanted to go over this again very carefully, emphasizing their potencies are different, their preparations are different. Their dosing will be different. So the one I use very commonly in my practice is Botox on a botulinum toxin. That was approved by FDA in 1989 for different muscle groups in adults. And I'll go over the history very shortly too. And then in 2000, the B toxin, the Reusable botulinum toxin, was approved again for adults for different muscle groups. Then came the Dysport, which is again a French manufacturing company making this Evo botulinum A toxin that was approved by FDA in adults in 2009, and then 2010 came Xeomin, another A toxin. Now when we go over the history, there's a lot of information there, but I just wanted to put this out here to show you. 2002 is when the neurotoxin, the Botox, was actually looked at in different studies for indications such as cerebral palsy. Before that, it was the eye muscles, the strabismus, the blepharospasm, the eyelid, the neck muscles, and all that good stuff. But 2002, cerebral palsy came into place. In 2010, FDA approved Botox for spasticity in the limb. So this is not the neck anymore, this is not the eye muscles, this is not the bladder, all these other indications for Botox. Finally, they're doing the limb studies and getting it approved. 2015, April 2015, they expanded the indication to be used for other muscles on the upper limb. Again, all adults. And they added the thumb muscles into the wrist, elbow muscles. July 2015, they finally again approved the other toxin A, Dysport, for similar indication, adults, upper limb spasticity. December 2015, Xeomin, the third botulinum toxin A, is approved, similar indication. And the last one is January 2016, just like 8 months ago, they approved the Botox used in adults. But this time it's the lower extremity. Finally, it's the lower extremity. So, as far as pediatric, it's not FDA approved yet. And we'll talk about what that means in a minute too. Now, lots and lots and lots of studies in the literature for use of toxins in cerebral palsy spasticity. And there are different types of studies, but the short story is we have a lot of experience in this. And we have a lot of good studies that guide us in selection of our treatment modalities. Pediatrics, yes, it's very different than adults. And as pediatric providers, we all know that the dosing will be very unique. We have some guidelines. I think the first one was out in 2004. And then we had another set of guidelines, very similar, listing which muscles and how much should be injected into each muscle. This was 2007. Not much has changed since then in terms of the dosing. The important thing is when we do our dosing, we need to pay attention to the children's weight. So to me, the most limiting factor when I do Botox, when Dr. Jen sends me a patient or I see another patient, we're talking about how we can use this as another modality, adding to the other treatment modalities. What I find limiting is the weight, because at the end of the day, the total amount of Botox I can inject is determined by the weight of the patient. Now, there are other factors that play into it. Of course, the duration of the response. When I do it multiple times, it matters how long it lasts. If it is every 6 months, if it is every 3 months that we need to do it, it makes a difference. The muscle bulk, the muscle size, the size of the kid, the number of muscles we have, targeting, the severity of the spasticity, how bad the spasticity is, or sometimes the dystonia is. And then the results of previous therapies or other therapies, how Botox is going to help in adjunct to everything else. And of course, at the end of the day, goals, the objectives, what the family's goals are, what my goals are, or what the referring physician's goals are. We need to put it all together and then come up with the optimal dosing for our kids. Now, like any other medication, the toxins, they have side effects. And if they're not dosed right, if they're not done correctly, they may cause problems. So the most common ones are the weakness. If the patients are overdosed, we may really make our kids weak. And by taking that tone away, we're already we're already causing some weakness, and that's on purpose. We know that. Sometimes we want to make them weaker so we can start from scratch. And in therapy, teach their brains to use those muscles, to fire those muscles in a correct way. But again, we need to balance it out so we don't result in some unwanted weakness. If the toxin spreads and comes up to the pharyngeal area, it may cause problems with swallowing. So it's very important that we dose it right, we use the right technique, and we don't inject it into the bloodstream, or we don't, again, by causing overdose, we don't cause a distant spread and problems with the swallowing. Some local reactions that I see sometimes, yes, it may make the muscles a little sore. I've seen a few cases of swelling, very focal swelling, little red bumps around the injection sites. These are all very self-limiting, and they're not really, long-term effects, and they don't really cause that much of a problem. Rarely I've seen the flu-like syndrome, especially with my older kiddos that can tell me they had the low-grade fever, self-limiting, and they felt tired and kind of sore in their muscles for a few days. But I usually ask them to use the good old Tylenol, ibuprofen, and they're fine with that. Infection, I've never had that, but it is possible. It's multiple needling. You go through the skin, you can always introduce some bacteria from the skin into the muscle. And of course, the most important is the breathing, the respiratory problems. Now, this, again, is due to that distant spread and overdosing most of the time. And if the patient has any premorbid lung or underlying lung condition, they're higher risk. So in those kids, we need to be more careful in terms of the dosing, and we need to make sure we're injecting the right muscle and using the right technique. Correct dosing is very important. Guiding of the injections. So I personally use my little amplifier, the EMG, electromyography machine amplifier, that tells me I'm in the muscle, and I'm trying to find that area of the muscle I showed earlier, the end plate, making sure I'm getting the best out of that neurotoxin. Other providers use ultrasound for guidance. Again, at the end of the day, we know where those muscles are, we palpate, we know our landmarks, but it doesn't hurt finding that good spot before you inject that toxin. Now, the handling, the technique is important. The way you use your normal saline to come up with different dilutions is important. Going back to dosing, and the storage and all that good stuff you have to deal with, it's important. Training is, again, you have to be trained in how to do the injections, so you know how to palpate, how to find those muscles, how to find your landmarks, and how to use your needling and get the best results, hopefully. I wanted to include this because this is part of what we do with our patients, and this should be part of our talks with the patients' families. There is an update on FDA. There was in 2009 after reports of 2 cases with some distant spread and some problems with breathing and swallowing that ended up in some major complications. Again, the premorbid diagnosis is important. But FDA did say in their boxed warnings they were going to include all that distance spread is possible. And the symptoms have mostly been reported in children with cerebral palsy being treated with the toxin for spasticity. And this is a use of the drug that has not been approved by FDA. So pediatric use is not approved. Symptoms have also been reported in adults treated for approved cases. So this is true for across the spectrum of patients or diagnosis. Different products, different potencies, and they were all named in their safety alert. Bottom line is there are a lot of studies that we follow as providers. There's a lot of medical literature. There's a lot of evidence what we use as our justification before we come up with these plans. And in 2011 there was a good study that kind of evaluated the comparison of events pre and post, before injection to after injection. And there was no increase in adverse events post-injection. So what I'm trying to say is it's very hard to say what happened with those few cases, but all the evidence points towards a pre-morbid condition that made those kids higher risk. Something to keep in mind. And again, the recent literature reassures the safety for injecting the toxin when used in all different functional classification levels. So whether it's mild or severe, spasticity or CP kid, they can be used. Now, use of drugs are approved by FDA for different indications, and sometimes as providers we use them for off-label indications. An approved drug may be prescribed for uses that are not included in the approved labeling, but it may be still okay, it may still be appropriate to use, it may still be supported by medical literature and evidence, and that's what we try to go with when we use neurotoxins. Drug interactions is important. As providers, we need to be aware of this, and we need to question our families. Some antibiotics, aminoglycosides that are used for bladder infections, kidney infections, anticholinergic medications that may potentiate effects. So if they're on other muscle relaxing medications, other anticholinergics, we need to be aware of that and warn the families. And muscle relaxants potentiate the effects, but then we do use this. This is very common in our patient population. They are taking some type of muscle relaxant. On top of that, we're using the focal neurotoxin injection. Post-injection, in itself, the neurotoxin is not going to be the answer to our problems. So post-injection, we need therapies, we need the splinting, we need the positioning, we need everything else we're doing before the injection to, again, maximize the outcomes. So if you're using the splints, it may be a good idea to actually increase the splinting time, or revisit the splints and make sure we're positioning, stretching those muscles that we injected, because now they need more stretching, they need more positioning. I use a lot of serial casting, especially with the ankles, when I inject the muscles that control the ankle joint, to get better results from the neurotoxin. And sometimes we use different modalities like, e-stim, electrical stim, to help with the absorption of the toxin to enhance the effects of neurotoxin. So electrical stimulation with increasing muscle activity post-injection. So these are all good things to remember. Now, just to kind of support that idea, I do use a lot of casting. I have a wonderful team, and I'm sure you do too. Neurotoxin in itself is not going to accomplish or help me gain the range of motion gains that I have in mind. So serial casting, or what I call functional casts, help too. Sometimes for nighttime we choose to do the functional casts that are removable. And serial casting, it takes some trained staff. So if you have that person who can see your patient every week and change the cast and make sure they're monitoring the skin and make sure they're doing their measurements and documenting the gains, I think it's very helpful, and I get really good results with that. Positioning is huge, whether it's splints or different devices. Again, we will always talk about positioning before or after injections. Now, I did include a few of these slides just to show that I do use neurotoxins for the neck area too. It could be with a CP kid that has what we call the torticollis type of finding with the neck muscles, or they may have cervical dystonia, again, to help with their muscle tone. And these are the muscles I inject. And different types of neck postures. Again, neurotoxin may be a good modality to add to your treatment plan. Now, for drooling purposes, I'm kind of on the fence. I will do it if we have tried everything else, including therapy modalities and positioning and some medications. I have an ENT surgeon I work with. They do a lot of injections too, and my outcomes are 50-50. So I don't know if anybody else has anything to say on that, but I do offer it as a kind of as one of the last resorts, and sometimes it works, sometimes it doesn't. The point with that is with drooling, it's very important to do it under ultrasound guidance, because then you can really hit those salivary glands. Again, it doesn't matter if you inject them or not, you still have to do your therapies, whether it's drooling or torticollis or whatever else. And this is just to show that I do use a cold spray to numb it up. At least the skin is numb after this freezing cold spray. My kids will still feel it because I go deep down to the muscles, and it's multiple injections, lots of needling. This makes me feel better. This makes the parents feel better. Sometimes it's good, sometimes it's not, because it may also trigger some of that startle response. So I have a few families that are like, please don't use that, and I'm totally fine with that. So I have 2 videos, if you don't mind running. The first one, this is a hemiplegia kiddo. And as you can see, this is my clinic. He's alert. I'm just using the cold spray. In this case, there's no pre-medication. There's no anxiolytic dosage. He's totally alert, and he's actually very helpful, and he's cooperating, and he's one of the sweet kids. So I'm feeling the muscle first, this is for the posterior tib. I'm trying to feel the muscle, palpate the muscle. After wiping it, I'm using the cold spray. I have my nurses to help me with positioning. That's my amplifier, the electromyography machine amplifier that I will use as a guiding tool.
Helps her know that she's in the correct muscle. And that sound lets her know.
The sound kind of guides me, and I can tell if I'm in the muscle, first of all, but also if I'm getting closer to that end plate. Again, it's a teamwork, and I can't do it by myself because I need a lot of positioning, and by the time I get to the muscle and feel it and all that, I want to make sure, I'm not traumatizing my patients. So it's always helpful having, if you have child life, that's wonderful. If you have nurses, parents, siblings that can distract our kids, that's wonderful. And I also do this in the OR. There are certain kids that we choose to be recommending it in the OR, or families choose to do it in the OR under general anesthesia. Then I would be using a nerve stimulator. It wouldn't be the exact same device, but a different device to guide my injections. As you can see, it's multiple needles, multiple injections, but he's wonderful. He did a wonderful job. We're done. It's going to help a little bit, right? Okay. That was good. Well, the good news is this takes about 10-15 minutes, and they're out of the clinic. Now, this is another one, more involved patient of mine, and this is the upper extremity. Basically the same thing, my EMG amplifier, my nurse helping me feel the muscles and positioning and holding it down, cold spray to numb it up somewhat. And aspirating, making sure it doesn't go into the bloodstream, hopefully. So it's the wrist flexors I'm targeting in this case.
How tight it is, and she aspirates and injects.
And I'll tell you, patients, your kids, they're tough, they're very strong. I have a lot of kids, families are like, we're fine, let's not do the OR, let's do it in the clinic, and it is doable, it totally is doable. But if you need to give them a little bit of the Versed to pre-medicate and help them relax, that's fine, we can do that. And sometimes, again, general anesthesia is the best way to do it. So that's about it. Thank you. Any questions I can take?